Hello, thank you for being here today, whether it's the morning, afternoon, or evening, wherever you are. I want to take a few minutes of your time to discuss something that's really interesting to me. It is basically how to optimize your results when you want to perform a joint reconstruction for arthritis of the thumb with a total implant. So basically how to get better results. The reason behind this conversation today is someone. Back in July 2020, I met Patrick. Patrick was at the time a 52-year-old man, very nice person. He was married, 2 children, and I believe he worked as a developer or an engineer. Patrick was very active and he loves to play with his kids. And then one day he fell down the stairs and hurt his hand. So of course he went to the emergency room, had x-rays to check if he was, how badly he was hurt. Then luckily for him, there was no fracture or anything really serious. However, after a few weeks, some pain remained at the base of the thumb, enough that he decided he needed help. So he came to see me. And and this was maybe a year later after this injury, after the fall, we did an x-ray for him. And we realized that, thank God, there was no fracture, but there was now arthritis at the base of the joint. And the arthritis was significant enough that he wanted to have treatment for it. So we performed an operation, which was a joint replacement with a Maya implant. And we were able to do this under local anesthesia, which is known as wide awake local anesthesia without a tourniquet. This is the technique we use. We performed the procedure and everything went very well. And Patrick was ecstatic. He was very happy with the results, the early results at the very least. The reason I say that is because unfortunately, about a week later, we got a phone call, and Patrick had been wearing his big, plushy bathrobe while he still had the cast on and a big dressing. And then when he tried to remove his bathrobe, he really pulled on the sleeve because it got stuck. And then that somehow pulled on his thumb. And unfortunately, he heard a pop sound that he didn't like. So, and I certainly didn't like it when he told me over the phone. So we brought him in, we had x-rays taken, and sadly, the joint was dislocated. So we took him back to the operating room immediately, again, using wide awake local anesthesia without tourniquet. And the patient could be operated right away because he didn't have to be, fasting or anything like that. And we performed the surgery, we opened him up, realized that there was no fracture, but we could just replace and reposition the implant in place, the same implant. And then we closed him up, put him in a cast again, and then he was good to go. After that, he was immobilized for another 2 weeks. And then he was encouraged to move right away. And the rest of is history. It all went very well and he was very happy. The reason I bring this story up and why this story inspired me to work on this talk was to help my colleagues prevent problems like this one and the other problems that can arise when you do surgery on the base of the thumb, but also how to deal with complications when they do happen. So I hope you will get a lot of information out of this presentation today. So in essence, what I want to tell you is that it's possible to get fantastic results with this great operation that is a joint replacement for the basal joint of the thumb right here. Very much like is done every day for the hip. Now we can do this for the thumb. But in order to create those very good results, we need to have a very careful patient selection. We need to be very meticulous with the technique. we need to use the best implant possible. I would advise using Wallant anesthesia because it's less invasive and it's a lot more accurate. You can do a lot more with less than you would with regional or general anesthesia. And then, of course, you would need to immobilize the patient very quickly because nobody wants to be in a cast for a long time. And then you want to optimize healing with nutritional support and whatever technique you may have at your disposal, rehab, MLS laser and whatnot, to compress the recovery time to the minimum possible. And if you do all of those things, you can have fantastic results and you'll have very happy patients. Now, total joints to replace this, total implants to replace this joint are not new. If we go back to 1971, Dr. Jean-Yves de la Caffinière was obsessed with developing an alternative to the conventional treatment, which was at the time taking out a piece of bone to prevent thumb pain. But the piece of bone was there for a reason. So he was obsessed with finding a solution, a more modern approach to treat this problem. And that's when the adventure, the journey that led to the refinements of joint replacement of the thumb started. In North America today, only about 2% of surgeons use this technique to treat arthritis of the thumb, which means that 98% still use older techniques. In Europe and the rest of the world, the situation is a bit different. And today, there's about 13% of cases of arthritis of the thumb that are treated with a joint replacement. So one of the reasons for me to talk to you today is because I want to close this gap between what's going on in Europe and what's going on in North America. So since Dr. de la Caffinière, there have been many refinements and new implants that have been developed to get better and better results. And as you can see here, there's many. I'm not going to go over them, but you can see the most recent ones are the touch implant that unfortunately are not available in Canada or the United States yet, but hopefully will be there soon. My personal interest in joint replacement goes back to the early 2000s, where I was working in a private hand surgery center in Brussels, and Dr. Kinnan and other doctors there were really pioneers for this procedure. So I got involved very early, I'm going to say over 20 years ago now. And this is when my interest started, and this is where I started getting a lot of experience with this procedure. Now, when I moved to Canada back in 2005, many of the implants that I was familiar with were not available. In particular, the RP implant that you can see on the left side here of the screen really looks like a mini hip implant, but it wasn't available. So the ivory implant, which was very similar in design, is a modular implant. As you can see, has multiple little components that you can choose. And this was available, so I started using that. Unfortunately, the ivory implant became discontinued, and so the Maya implant was made available in Canada, and so I started using this one, which also looks very much like the ivory implant, which itself was inspired by the RP implant. All this to say, they're very similar, and the Maya implant is what I use today. Now, if you want to have good results, you need to choose your indications very well. So you can't do this procedure for just anyone. So it's mostly, in front of you right now, you see a classification of the typical 4 stages of arthritis, stage 1 to stage 4. This would be reserved for stage 2 and stage 3. So probably not for the most terrible advanced and deformed thumbs, and probably not for the very, very early cases, stage 1. So stage 2 and stage 3. Now, more important than choosing who you're going to do this to is to choose who you're not going to do it to. Because if you carefully select your patients, you'll decrease your complication rates. So one of the things you need to pay attention is that there needs to be enough bone stock to receive the implant. So if the height of the trapezium is not tall enough, then I would advise not to do this procedure. A grade 4 arthritis should be avoided, like we discussed before. Then, of course, if you have poor quality of bone, you should probably not do this either. I'm thinking older patients with osteopenic bone, probably avoid that, because either you'll end up with a fracture during your surgery, or you will end up with early complications like migration of the implant through the soft bone. So again, if you want to create better results, I think the anesthesia technique is very important. Now, on the screen is my mentor and friend, Dr. Don Lalonde, who has been pioneering Wallant anesthesia and surgery around the world for the last maybe 20 years or so. Now, he's Canadian, and one of the reasons Canadian surgeons are so good with local anesthesia compared to many of their colleagues around the world is because, unfortunately, we, for the longest time, did not have access to a lot of anesthesiologists in the hospitals, conversely to other specialties. So we had to become very good with local anesthesia. And this is what Dr. Lalonde has done. But more importantly, he's been traveling around the world to show and share his experience and the experience of Canadian hand surgeons with the rest of the world for the benefit of patients. So I really believe that you'll get superior results if you use Wallant to do this procedure, and your patients will be a lot happier too. This is how it's done. You would use about 45 to 50 cc's of a mix of lidocaine with epinephrine, and that you'll inject all around the base of the thumb, inside the joint, around the joint. And then you need to wait about 45 minutes to get good vasoconstriction. And if you do that, you will have a painless patient, obviously, but you also have a bloodless field, and you'll be able to do this surgery in the most perfect way that you can. Now, the approach that you're going to use to do this is important. There's basically two ways. One is dorsal, one is volar. I prefer the dorsal approach, just because I like to keep the thinner muscles attached on the thumb, which means a shorter recovery after surgery. Both approaches are good, but either way, what is critical is that you get very good exposure of your joint so that you can do the procedure without being constricted and you're not working in a hole. So in order to be able to mobilize the base of the metacarpal bone, which is this one here, you need to release all the ligaments around and not be afraid to release them, because it needs to be very mobile so that you can work inside the joint. So that's critical. Then another component of the technique that's really of the utmost importance is to remove the osteophytes. The osteophytes are these bony spurs that are growing around the joint. That's part of the disease. And if you don't remove them, when you do the joint replacement, there's a problem that can happen, is that there's going to be there's going to be excess pressure on the implant, which will cause the implant to dislocate. So you need to resect the bony spurs that you see that are pointed out by the arrows here. Then, and that is something I've learned over the years, I advise not to resect more than 1 millimeter of the trapezial bone. What I mean is, before, we would advise to remove about 2 to 3 millimeters of the trapezium to remove the destroyed cartilage and the subchondral bone that it might be a part of affected by the disease, which is arthritis. But what I've learned is that you really don't need to do this. And in fact, if you preserve the subchondral bone that is actually quite hard, this is great to support your implant and will decrease the risk of having an implant migrate proximally. So what I do now is I resect the osteophytes and I drill right through the remainder of the cartilage and the subchondral bone, and I try to preserve as much bone stock as I can. And that's even more important if you don't have a lot of height in your trapezium, but you should have a minimum of at least, something like 8 millimeters to be able to do this. But this little trick will help you. Now, you have to select the cup. The cup basically comes in different diameters, 8, 9, 10 millimeters. The depth of the cup is about 7 millimeters. Now you understand why you need at least 9 millimeters of depth to support that cup. And it comes with little spikes, and the spikes are there to prevent rotation of the cup. Typically, most of the times, it's going to be a size 9, but you know, with a bigger patient, you may want to go to a 10, or with a very small patient, you might go with a smaller cup. Then the next critical thing is when you're going to start drilling in the trapezium to make room for this cup, you really need to hit it in the middle. So you're going to use either a 1.9 millimeter drill or a K-wire or an awl to really identify the center of the trapezium. And then that's where you're going to start drilling. Very important. If you don't do that, you may end up with a fracture of the trapezium during surgery or early failure of the implant because the biomechanical forces are not distributed properly. So you're going to basically ream into the trapezium. You can use power or hand. I prefer hand because you have better control. It's more delicate. And then you're going to use a trial cup, which means it's not the permanent cup. And the cup has inside an insert part that's made of polyethylene, PE. And that can be either retentive or non-retentive. What that means is that if it's retentive, the head of the implant will come in here, and the border of the PE will capture it, so it's stuck in there. If it's non-retentive, what happens is it just gets in there, but it's not stuck, so it can really piston, which can lead to an increased rate of subluxation or dislocation, rather. So this shows you how completely painless drilling the trapezium is under Wallant. As you can notice, there is no blood. And there's absolutely no reaction to pain because there is no pain. The patient is fully awake and is actually following the procedure while they're listening to music. Then you want to move on to the metacarpal bone, and you're going to just prepare the medullary canal with different instruments. And you're going to do this very nicely, very carefully, because you don't want to break the metacarpal bone. And you're going to do it so that the rasps and then the temporary implants, the trials, will just sit very nicely and flush on the cut surface of the bone. And that's what you want. So you want to be well positioned and flush. And then, of course, you're going to put the trial implants in. Then you have to choose a neck. The neck is what articulates the metacarpal stem to the cup. And it can come in different sizes, medium, large, and extra large. You want to choose the right one because you don't want the reconstruction to be too loose or too tight. So a little pistoning of maybe half a head is recommended because, again, you don't want this reconstruction to be too tight because you want good range of motion for your patient. So if you do that, you'll get great results. Then, and that's a huge benefit of Wallant, is that you get to try active and passive range of motion on the table. And so you're going to ask the patient to move around. And as you can see here, the patient starts to move their finger, their thumb, but I get to watch what's happening inside as they're starting to move. And I'm looking for impingement, conflicts, mechanical problems, so I can adjust them right there and then. And then I want to see full range of motion. And so I ask the patient to move their thumb all the way through this small finger and all the way down to the palm, and then to open the hand. And then I want them to see them. So the patient's watching this. And so they know in their head how well their thumb is moving, how well the implant is working. And that's going to guide them later when they recover from the surgery and when they're going through the rehab program. As you can see, this is happening on a wide awake patient who's very happy, tapping to the music. This is the power and the beauty of Wallant. So then you're going to close the capsule. I like to dorsalize the abductor pollicis longus. I don't use a drain because it increases the risk of infection and there's really no blood collection there. I like to use a little bit of Micaine for patient comfort, so they have no pain for about 8 hours, 12 hours, something like that. Then I put them in a first web splint made of cast for about 1 to 3 weeks, depending on the stability and how happy I was with the reconstruction. I put them in a big bulky dressing like this one here, and of course I send them for x-ray. A big bulky dressing like this will help the patient understand that they shouldn't be doing too much with this hand for the first couple of weeks. Keep it up and be careful to avoid accidents and dislocations like it was the case for our friend Patrick. So then I will have my patients move their thumbs at about week 1 if they're stable. And a lot of times hand therapy is not mandatory. It can be useful to expedite recovery even further, but conversely to a trapezectomy, often it's not needed at all. What I like to do though is to film the surgery and the range of motion as you've seen before, and send this film to the therapist so that it's almost like the therapist was inside the operating room with us. So they know exactly what we did, what kind of range of motion we got, and they're going to help, and that's going to help them provide a more personalized and better rehab program for this patient. And as a result, higher patient satisfaction, but great results. Now, complications, the best way to deal with complications is to prevent them. So if you want to prevent an infection, you want to give antibiotics for about 24 hours per mouth, no need for an injection, and more than 24 hours is really unnecessary. If you want to prevent regional pain syndrome, vitamin C, 1 gram a day for before the surgery, during the surgery, and after the surgery. I tell my patients take it for about 3 months. I of course, will educate the patients very, very well. And I will do that differently for each patient, knowing what their level of activity is. So that's very important. Dislocation can happen when they do things they're not supposed to, or accidents happen like it did for Patrick. So how do you prevent that? Patient education, resection of these osteophytes. Remember the bony spurs I told you about? They need to be removed so that they don't, dislocate the implant. And then you want to make sure the cut was right in the middle of the trapezium, as we said before. Neuroma is basically nerve pain in this area. You should just not hurt the nerve, but early mobilization will prevent scarring again around your nerve, and that can be a cause for nerve pain. So if you want to prevent that, be very meticulous with the surgical technique and get your patient moving early. This is a typical result at about just over 12 days after surgery. As you can see, not very swollen, good range of motion. Remember, the patient knows, because they've seen on the table, that they're supposed to be able to do this. So this will guide them during the recovery. And if you do that, patients have better results and you'll be a happier surgeon. Healing optimization is very important. I like to make sure my patients get all the nutrients they need for their wound to heal. So I like to prescribe a multivitamins preparation. I like to give them coenzyme Q10, which is a great antioxidant. I use the devil's claw, which is a natural anti-inflammatory agent. And I like to use technology to even leverage that and make recovery even shorter. I use the MLS laser, which is a robot that fires 2 types of lasers into the area to minimize pain, swelling, and expedite recovery. So patients come for about 2 sessions a week after surgery, and we can start this at week 1. And so you can see on the left side of the screen, you can see the perfect triangle that's moving around the area. You get a perfect triangle when the 2 lasers are perfectly set. Then you know it's working. By the way, this triangle that's moving, you cannot see with the bare eye, but the phone can see it. And so this was filmed with the phone, obviously, and you can see the triangle, and you can see a very happy patient going to the treatment. So outcomes, there are many studies now that have been comparing joint reconstruction with trapezectomy, which is removal of the trapezium, and ligament reconstruction, and the jury's out. Results are superior in terms of recovery, pain, strength, range of motion, and cosmesis. the recovery is always compressed, is also compressed to a much shorter period of time than trapezectomy that can easily take 9 to 12 months to fully heal. And then we have about 93% of survival rates for these implants at 10 years. And this is for earlier implants. So today, survival rates will probably be much longer with the newer implants. So again, as I said at the beginning, I think we can today optimize our results and get perfect, almost perfect results if you select your patients very carefully, have a very, very meticulous surgical technique, use modular implants, which means you choose the right size for each component based on your patient. So there's no such thing as a one-fits-all, because one fits all fits no one. Use Wallon for all the reasons I've said before. Move patients early, and you know you could do that because you've seen it on the table. Use nutritional support and use whatever technique you have, whether it's conventional hand therapy, laser therapy, magnetic wave therapy, whatever you can do to shorten that recovery. If you're going to use magnetic wave therapy, make sure your implant is MRI safe. Thank you very much for taking the time to spend with me today to learn about this, because if you apply those tips and tricks, you will have great results. Your parents, your patients and your parents will be happy, and you'll be a happier surgeon as a result. Thank you very much. And more importantly, have fun doing it.